On a little bit of a time crunch here, so we're going to move things along. We have a very esteemed panel here, and I'd like to be very grateful to the fact that we're the last, because not everyone is leaving like they usually do when the pediatric panel starts off. Our financial disclosures are listed, and we have, as I said, a distinguished panel here. Those of us who do pediatric retina are used to taking care of our problems for our adult colleagues, which probably explains why one of our panelists, Kimberly Drenser, is not here today, because she's back home covering call for her adult colleagues. Nevertheless, we still have an excellent panel here today with Nina Barakal and Cindy Toth, Chara Basirli, and of course, Paul Chan. We're gonna do big questions in pediatric retina. Following up on Yoshi's talk, we're gonna talk about prophylaxis and type 1 sticklers. We're going to address giant retinal tear management after the treatment of ROP, and then, of course, follow up on Bob Avery's excellent talk on safety concerns and anti-VEGF. Now I'm going to give them each 30 seconds to provide their own wisdom and or wit. So type 1 sticklers. 3 years ago, Kim Drenser was up here and she was talking about laser barrier prophylaxis for 360 degrees in patients with sticklers, and showed several cases where they'd completely unzippered. And this is 2 kids who came into my practice, had been treated elsewhere. One eye was lost in both of them for type 1 sticklers. And then, of course, I've got their 2 younger siblings. Obviously, one of them here is treated. And I started talking about this with Phil Ferrone in an airport right after Emmy's meeting in Utah. And I was like, how are we going to manage these? I don't think laser is going to work well. He pointed me in the direction of the Cambridge Eye Study, which showed that cryoprophylaxis does great at preventing retinal detachment in type 1. I'm not a big believer in cryotherapy. And I said, what do you do? And he said, I do buckles, prophylactic buckles. And I said, oh, that's interesting. So I was looking at this other child, and I said, I'm going to go and do a buckle. So I want to start here with Chara. What do you think about for prophylaxis? Are you doing any prophylaxis in type 1, and what kind?
Yeah, given the high rate of detachments in these eyes, 54% in untreated eyes and up to 80% if there's fellow eye detachment, I think prophylaxis should definitely be considered. And who should have prophylaxis? I think it's good to have genetic testing to show collagen 2A1 mutation and diagnose type 1 Stickler syndrome. That's the best data we have. And in terms of what type of prophylaxis, Cambridge study shows very nicely that cryo treatment is effective, very effective. And I think we can assume that laser treatment applied in a similar way will also produce similar results. In terms of prophylactic buckle, we do need to consider the additional the potential lifelong risk of strabismus and buccal extrusion or infection. So I think, based on that, based on available data, my initial recommendation is typically laser prophylaxis. And in our hands, when we do this procedure, we reduce our redetachment rates from 50% to 5%, very similar to the Cambridge study.
So someone the other day told me that diplopia is better than noplopia, and I forget who it was, but it's better to see out of both eyes. And I went ahead for the prophylactic buckle in this patient and did quite well. It's only been 4 months now, but I've started a series of these patients. And when we did this panel back at the ASRS, I think it was about 4 out of 5 were doing prophylactic buckles on occasion. So now we have the other problem, which is giant retinal tears and or combination giant retinal tear dialysis. And again, you see this in Stickler syndrome. You can end up with good outcomes. I did buccal VIT oil in both of these eyes. You can see it in Marfan's. So Cindy, how do you approach these patients?
So as was mentioned by Yoshi in the last talk, we're treating the patient, not just the eye. So you're thinking about the second eye because we have bilateral disease. Marfan's different from the Sticklers, so Sticklers I'm going to buccal VIT most of the time. It does depend on the extent and where the end point of that giant tear. So here in the Marfan's it's superior. Sclera is more of a problem in Marfan's, so I'm more likely to do a vitrectomy with gas or oil rather than a buckle. The lens is always a problem. The lens has now been removed by the ophthalmologist, so it's not a consideration here, but the movable lens in the Marfan's would be a concern and something that will typically remove the lens at the time of surgery. Sticklers, buccal VIT, either gas or oil. Often oil needed for kids because of the inability to cooperate, particularly when the tear extends inferior.
I've always been a big fan myself of the Buccal-Vit. Oil is good, take it out later, it worked out well. So one of the big discussions that we've been moving on in retinopathy of prematurity is who to treat, how to treat, and then how do we manage these patients. And I'm going to turn this over to Paul Chan right now to give us 2 cases.
Yeah, so I think we're seeing more and more of these cases as we inject anti-VEGF. This is a micropreme, 24 weeks, presented to me. You know, I sort of say I never saw this in New York, but I see it in Chicago now. You know, 48 weeks of gestation and had multiple anti-VEGF injections, and presents to me like this. So you can see here there seems to be some neovascularization in the right eye, and then it's hard to really see the avascular retina in the periphery, but go on to the left eye, and you know, you see that there's some avascular retina in the periphery, but it's hard to say. So my question actually, and I'll sort of throw this out, see how much time we have, but maybe to Nina, what would you do next?
Fluorescein angiogram?
There you go. I love you. So, you know, this is why we're good friends. So we did our fluorescein, and you know, clearly you see the avascular retina and the neovascularization, and then go on to the left eye and the avascular retina, right? So the question now is, what is this? Is this recurrence? Is this something that you treat, and so forth? And you know, I think that this is the debate that a lot of us have now in terms of what is the definition of recurrence after anti-VEGF. And when you look at the literature, it's interesting because right now there's no consensus agreement on what that means. Does it mean that you have avascular retina? Does it mean that you have new NV? Do you have to have stage 3? Can you have just a little bit of stage 1? Do you have to have recurrence of plus disease? So I think that for most of us, we would treat this, and I treated this. Right?
And I agree with that. You know, we go ahead, treat him, you put him under anesthesia one time. In the interest of time here, I'm going to skip the next case and then just kind of show you what to think about when you're looking at reactivation in anti-VEGF. You can see that this is one of the patients that I treated. Over time, it gets better, and then all of a sudden, starting around anywhere 28 to 48 days after, we start to see reactivation, and this is concerning to me. I just went in and lasered it because you know, I don't want to manage this patient to the point where they end up with a retinal detachment. Which brings us to Nina. Let's talk about safety in anti-VEGF. What are your concerns about their overall health?
Well, my dear Darius, I think these 2 papers we know well, and Dr. Avery went over one of these, but the reality is that this is registry data. It's retrospective, non-randomized, with a lot of biases. It has selection bias, and it has treatment bias, so they're not necessarily great papers. We have 2 prospective randomized trials that show that anti-VEGF is superior to laser, and that show that there's no difference in mortality between the 2 groups, the laser group and the anti-VEGF group. And in reality, we can't forget that one of the major neurodevelopmental issues is blindness.
I agree with that. So, which brings us to our chance to have some wisdom, which brings us first to Cindy.
So your question was to me before this is, when is OCT absolutely necessary? As you can see here in this infant with stage 4B retinal detachment with ROP, identifying foveal disease. Children who come in, presumed amblyopia. No one has looked at the macula with OCT. Remember, amblyopia is if there is not a pathologic process going on, and we often find macular disease in young children that's not recognized.
Okay, and it brings us to Chara. You got the kids, you got to put them to sleep. What does the mom want to know?
You know, we get this question about risk of anesthesia because there's some concern for neurotoxicity based on animal models, but human cohort studies produce very mixed and conflicting results. So finally, this year in Lancet, we had the first randomized trial to assess the effect of general anesthesia on neurodevelopment in infants less than 50 weeks of postmenstrual age and born more than 26 of gestational age, very similar to the patients we treat. And the study showed clearly that 1 hour exposure to general anesthetic does not cause neurodevelopmental deficits. It did not answer the question about longer anesthesia or repeated anesthesia. But the bottom line is that short single exposure to anesthesia appears to be safe for patients undergoing retinal surgery.
Paul, you get robbed a little bit. You get 20 seconds.
Okay, so you're talking to me?
Yes.
Okay, so he wanted me to talk about artificial intelligence and ROP. Very simply, I think it's the future. I think we have proof that it works and it is going to happen. I would have the privilege of working with Mike Chang, whose group developed something called the IROP system. and we've shown that basically it works as well and sometimes even better than experts. We have an FDA submission, so this is going to happen, and I think it's going to be great for especially resource-limited settings.
And Nina, who should be doing gene therapy in kids?
Well, as you know, I truly believe that kids' eyes are not just little adult eyes, they're very different. And I think that people who are doing kids' eyes all the time should be doing that surgically commonly. So gene therapy, retinal detachments in kids, Coats disease, that should be taken care of by people who are doing this consistently.
And thank you, panelists. I want to remind you, come back at 4:15.